right, everybody. Today, we're on the call here with Dr. Art Hatch. He's a pain management and rehabilitation physician. I say that right?
Physical medicine and rehab, but
Physical. Sorry.
my specialty is pain medicine too. So
Okay. Well, that's where I was going to start with you, is just saying, tell us a little bit more about your background and what kind of got you started with in your profession.
okay, well, good. Thanks for having me first, Mark. Appreciate it.
Yeah.
I am born and raised here in Mesa. I went to Arizona State for my undergrad.
Go
Did my
Devils.
medical school, yeah, absolutely. Did my medical school at Touro University in Nevada. Did a in residency in physical medicine and rehab at University of Arkansas, and then I came back here a little over 10 years ago and did my fellowship at Desert Spine and Sports Physicians, where I currently work, um, as I got hired on right after I finished my fellowship. Uh, Kind of the pathway for me was, a little bit of life experience as I grew up here in Mesa. I don't know, a lot of people grow up fixing their own cars and being a um, do-it-yourselfer, and that's kind of where my initial thoughts are going to be. I thought I was going to be, so I'm going to start my business doing something, fixing things. That's kind of where I went. I had an early injury when I was in high school playing baseball, where I dislocated my kneecap a couple times in a row, and it started to get me into the line of, oh, fixing things in medicine, fixing things in people could be kind of interesting. But one of the things that kind of hit me at that point is I had to stop playing baseball. The doc said, there's nothing really we can really actually do to fix this. You either give up the sport, or you realize that, you're going to keep having kneecap dislocations, and this is going to ruin your knee before you're 40. And that was kind of the old treatment for, patellar dislocation. And there wasn't really much to do. I could go do a few sessions of therapy, but the guys at the therapy office were like, your leg isn't weak per se. You have a little deficiency, and if the surgeon can't fix it, this could still happen again.
Mhm.
Um, and that started to kind of put me down a path of, well, how do you fix things that are not surgical, that maybe a therapist doesn't have all the answers for when you have some deficiency or some internal problem? And so things kind of work their way down, where further on in life, I actually pursued a few other things. I did real estate for a little bit.
Oh,
I was a computer programmer for a little while, and
wow.
uh, it just kept coming back to medicine. I got my undergraduate degree in biology, and those couple of years where I was trying to figure out what I was going to do, I kind of always had it in my head, well, I should be applying to medical school. That's what I really should be doing. Um, Eventually, when I got into medical school, you kind of have a first 2 years of introduction and finding out what you actually want to do. And I thought I wanted to do neurology. I wanted to be really good at diagnostics and work with nerves. They'd always fascinated me. Um, and through neurology, actually got introduced to my field, physical medicine and rehab. It's a much smaller field of medicine. There's only 28, or at the time, there were only 28 training programs for it across the United States, and there's not one here in Arizona. Um, and so uh, I did a small portion of my neurology rotation during med school with a physiatrist. That's what we call physical medicine and rehab doctors. And my just 4 or 5 days introduction was exactly what I was looking for. Maybe it wasn't so diagnostic heavy, but they took things that had traditionally been very difficult to treat, and they came up with all kinds of, almost like, we'll call them MacGyver treatment plans, where it wasn't anything that was so cookie cutter. It had to be individualized to the patient. It had to fit their needs. It had to adapt to their limitations. And realizing that it took a lot of kind of ingenuity and outside the box thinking to be a physical medicine rehab doc, that's what I wanted to do. So it leaned really heavily on problem solving skills and, coming up with something that maybe other doctors had kind of brushed off. So physical medicine and rehab, when we train in a couple of different areas primarily. So our residency, which is 4 years, focuses on spinal cord injury. So we're talking patients who are new quadriplegics, new paraplegics, and how they adapt to the world. It focuses on brain injury, patients who have nerve damage that is irreparable, and the way that they not only uh, deal with the world, but also think about the world has changed.
Hmm.
People who have severe concussions, things of that nature. It also deals with stroke. So patients who not only have physical impairments, but have cognitive impairments like difficulty to form words, uh, difficulty in performing tasks on one side of their body. Um, that exposure in PM&R also leads itself there's a kind of a joining factor between all those. Almost all of those patients deal with pain in one way or another.
Yeah.
And so you have to come up with kind of unique plans for how to deal with their pain. Pain can not only manifest itself as, uh, you know, actual physical disability, but it can manifest itself in other ways, such as increasing blood pressure, headaches. Patients who have spinal cord injury uh, end up with different responses in their body to when they have pain below levels that they can actually sense. And so it was kind of during this 3 years of physical medicine, the first 3 years of physical medicine and rehab, I realized I wanted additional training in relieving pain non-surgically. We're exposed to the surgical side of things, but I realized pretty quickly that was not for me. I didn't handle uh, being in situations where I couldn't make a difference and do something. I didn't handle that well. I wanted to do something for everybody, regardless of where they were at on the functional scale. And so about 2/3 of the way through, I put in an application and decided to do this fellowship here at Desert Spine. What we do here is we've kind of coined the term privademics, but we do a fellowship here at Desert Spine and Sports Physicians that's accredited through the North American Spine Society, um, where we train other doctors to do spine intervention to help them learn to integrate physical therapy into treatment plans, to be masters of diagnosis when sometimes it can be very elusive. We also do perform nerve conduction studies here at our practice,
Yeah.
and I've been doing it 10 years and I still love it. I find new things every day that kind of intrigue me, and I love the minutia of what I do, just continually striving to improve and grow.
Awesome.
Long
So
answer, but appreciate you sticking with me on it.
no, no, that's great. And I learned a lot right there just from what you said that I didn't know. And I've been, in the physical therapy realm for I think it's 25 years now. And so going, oh yeah, I didn't know that. For one, I said the name of PM&R wrong. But it just goes to show what you think you know. But this is good because I'm learning. So tell me, like, what are some of the major conditions or common conditions that you are involved in on a regular basis?
Uh, well, part of it's a little bit geographic. I mean, what we learn to treat here at my office, or what the doctors learn to treat, is basically um, uh, any type of pain that maybe is not visceral. So think like we treat pretty much everything, but like abdominal pain and soft tissue palate pain, that kind of stuff. We don't deal in
Mhm.
anything with TMJ, but we do focus very heavily on spine, joint, nerve, muscle, ligament, tendon disorders. So pretty much anything out there that you can think of, as far as pain wise, we attempt to make a difference in people's lives with. So we have lots of different things that we do. We definitely work well with physical therapy. I always include that in my treatment plans. We do medications. A large focus of what we do is based on teaching doctors different injections or interventions that can be done to help keep people off the operating table.
Yeah.
It's kind of a big goal of ours. And then when appropriate, we do send to physical therapy. So, or I mean, excuse me, edit that out. We do send to surgery.
Yeah. My parents, I mean, both my dad and my mom, you've provided care for, in the form of a radicular symptom relief, and so the lumbar region. So I know that that's something we commonly send our people your way. Like there are, as you said early on, you realize physical therapy sometimes, and other modalities as well, just don't always resolve the problem, and you need to escalate or elevate it, but not necessarily all the way to surgery. And so oftentimes you guys can be that intermediary
Yeah,
between conservative, totally conservative to a surgical, and you guys seem to
absolutely.
bridge that gap.
If you think of our specialty, we're kind of a little bit of a hybrid of like orthopedics and neurology. And a lot
Yeah.
of times, things that are, sent to us by other doctors are going to be cases of, I have pain here. And the surgeon says, well, I don't really know if that's where your pain is coming from. Or I treated what I thought was your pain and it didn't get better. Go see these guys and see if they can actually kind of unravel the mystery of where your pain is coming from. So we definitely see a lot of nerve pain. We see a lot of joint pain, and we see a whole lot of spine pain. So
And am I right about this? And you can fill in where I'm not, but you guys use advanced imaging with injections in a fair amount of what you do that will tease out or give us more information diagnostically. Am I going down the right path with that? And can you
yeah,
explain that?
absolutely. One of the things that people think we just do injections, and that's a big part of what we do. But
Yeah.
injections have more than one role in what we do. We certainly do injections to help treat pain, but one of the other roles that injections can play is to help kind of rule in or rule out any specific conditions based not only upon your response to an injection, whether or not I think you have hip pain and I do a hip injection and you get better, but also I can do injections using image guidance. And here at Desert Spine, I basically use image guidance for every injection that I do. There's very few injections that I'm doing that I'm not actually confirming that not only do I know where I'm at while I'm doing the injection, seeing the needle tip, watching the medicine flow in a good direction, um, but I'm also confirming that I am 100% certain that my injection went into your hip and that anesthetic should have provided you with relief of pain. But because it didn't, and I'm 100% certain I'm in your hip, I'm pretty sure the pain is not coming from your hip. So yeah, it can absolutely be used as a diagnostic tool.
A lot of people don't realize, and this recording will go to my staff as well as our patients that follow our YouTube channel. But a lot of people don't realize that MRIs are amazing tools, but they have a much higher incidence of you know false positives or false negatives than, say, like you just described. If you put a numbing medicine in a spot and you know it's there, that's a lot more information oftentimes than, say, an advanced image.
Oh, certainly. And when we're working through like the treatment plan of a patient, not only do we go through and take a really good history, go ahead and do a very good physical exam, neuro exam included in that as well. When we're going over the imaging, we visualize everything firsthand, and I'm usually actually looking at it with the patient because there's a lot of parts of being a radiologist and actually reading those MRIs on patients, that's very difficult. The radiologist doesn't see the patient, and so they read things in a very general manner. They're trying to explain as much as they possibly can about all the possibilities that could be wrong with a patient. Whereas I'm looking at it going, hey, Mark, you really have low back and leg pain. It looks to me like where your, pain is coming from would be the L5. Let's really focus in and see what this MRI shows. And we may look at it and go, man, there's just not a lot of pinch on the L5 nerve. But I'm kind of a good example of that. I had one years ago where I had a pinched nerve myself. Looked at the pictures, and the radiologist had read it that just said, it's just a little bit of narrowing around the nerve, really nothing to write home about. Looked at it for myself and thought, boy, that's just kind of right in the most compromising position it could be at, but it doesn't really look pinched. So what's my pain from? And so the next step was, well, we'll do an injection on that nerve, just a little bit of numbing medicine, one quick injection, 3, 4 minutes. And my pain resolved 100% during the time of the anesthetic, really confirming the fact, yeah, it may not look that pinched on an MRI, but that certainly is the problem that I'm dealing with. And by confirming it, I mean, it just makes it so much easier to create a treatment plan that's, really tailored toward what somebody's experiencing and their limitations. And also knowing the diagnosis with clarity really helps us as doctors to be better. We don't waste patients' time and their precious life here on earth, suffering. You can gain clarity and go right at the problem rather than skirting around it. So, yeah.
Yeah, tell me, I've been in your office before and watched you do your procedures, both you and Dr. Lee. I did some observation, and one of the things I saw you do was once was an ablation. Can you talk about what that is and how why that sometimes is done for some of your patients?
Absolutely. So ablation is definitely one of the most common things that we do for back pain. When patients have really any spinal pain that is really limited to their spine, it doesn't travel or shoot down their legs, except in a few occasions. But it's in the neck, in the mid back, or just in the low back. That can be a signal that they may be suffering from facet pain. And facets are small joints on the backside of the spine that are where we as humans develop arthritis most significantly. So an ablation is actually a treatment for arthritis. What we're actually doing is right next to the facet joint, there's a small pain sensing nerve called the medial branch. And we are doing an ablation or really thermally burning the nerve. We use a little bit of electricity to heat up a needle tip, and we're burning a grain of rice sized portion of that pain sensing nerve. And the hope is that the arthritis stops nagging you and that it just, it stops bothering you. In reality, most of the time it's more complex than that because in order to develop arthritis of the spine, there's kind of a degenerative cascade that people go through where they usually end up kind of not only having a few gray hairs affecting the discs, they may have had prior surgery, they may have had some type of scoliotic deformity or some other scenario where, or even a repetitive motion in a job over a period of years where the joints start to really suffer from repetitive you know, uh, injuries, or just even sitting at a desk all day is tough enough on most of us. So an ablation is how we treat arthritis of the spine. What we do here in the office is the first thing we're going to do in an ablation is try to determine, is your pain coming from those arthritic joints in your back? So we did an injection under a fluoroscope, which is like a live x-ray, where we take a picture of your spine and I can correlate it straight with your MRI, and I put a drop of numbing medicine on those pain sensing nerves that sense pain from the arthritic joints. So I numb up those nerves. We expect your back pain to just kind of turn off pretty much immediately. And if it does turn off, it really indicates that your pain is potentially coming from those joints. It's only supposed to turn off for a very short period of time, and then your pain is supposed to come back. But the information that provides us, it leads us toward what would eventually be an ablation. So an ablation is about somewhere between a 10 and 15-minute procedure where we actually create a little small burn on those pain sensing nerves. A week or two after that procedure, you should have fairly excellent relief of your back pain if the arthritis was the primary cause of it. And it is something that is done with very little risk to the patient. Because we're on the outside of the spine treating arthritis, we're not inside of the spine, right next to the spinal cord or around the nerves that go down the legs. Has a very, very, very low incidence of complications or, anything potentially that could go wrong with the procedure. And so you're talking about, potentially relieving arthritic pain. Now, ablation isn't a forever treatment. Usually the treatment lasts somewhere between a year and a half, but for a 10 to 15-minute injection here in the office, being able to get a year to a year and a half relief of pain consistently is a really great option for patients that are suffering from back pain. And I think the hard part that patients sometimes miss is the fact that back pain is is very difficult to treat with surgery. In fact, most of the most prominent and excellent surgeons here in town, if you just primarily have back pain, they won't operate on you because back pain is seldomly resolved with surgery.
Yeah, yeah. So, tell me, like, this is for as a physical therapist myself, I've been practicing for a long time. What are some maybe, if there are any advancements that I wouldn't necessarily just know about in your field that would benefit for me to know so that maybe I could, direct my people your way, if we're not the answer. Like, are there any new technologies or anything up and coming that's soon to be released that is going to make a big difference?
Well, I mean, there are the fields of regenerative medicine that are making strides in that. We're talking about Prolo and PRP, not only in joints, ligaments, and tendons, but actually using it in different portions of the spine. That's that's coming along. You know,
Okay.
we have great information and different studies that actually help us to know when to use PRP and prolotherapy and other regenerative things. This is like bone marrow aspirates. Some of the newer stuff that we're kind of waiting for longer term information on would be like basovertebral nerve ablation. So also another nerve ablation sounds a lot like radio frequency ablation, like I talked about a moment ago. But this is actually a nerve inside the vertebral body or inside the bone. And this nerve senses pain a lot of times from the disc or the top and the bottom of the vertebral body. And this can be useful in treating patients who have had bad disc pain for a long period of time that just didn't respond for whatever reason to traditional injections or didn't respond to physical therapy or medications. A lot of those people are stuck in jobs where they're sitting all day long or they're repetitively having to lean over and pick up things off the ground. Um, this is something that's been pretty prominent, I'd say, over the past 18 months to 2 years.
Okay.
Um, it started in a lot more of the academic institutions, and we're just now getting some word of insurance approval for this procedure.
Okay.
Um, we at Desert Spine like to be informed on the cutting edge of medicine, but we also don't want to do anything that might have long-term detriment. So there are some studies that are still kind of pending to come out that help us understand what the long-term ramifications of something like that might be for our patients. And so it's not something we currently offer here at Desert Spine, but that is something that's kind of on the horizon where there might actually be a better long-term treatment for discogenic pain that we haven't had previously. I think that kind of speaks to the fact of this is burning a nerve inside a bone, so you don't feel the pain from the disc. And that shows we really haven't been very successful at treating disc pain in the future. Several things have come up in the past, and they've just never given us that reassurance of relief of pain and not worsening the condition for the patient as they age.
That's awesome. We'll be watching for those advancements. Now, are you guys doing any of the regenerative stuff? Is that something you do there?
It is something that we do here. On a pretty regular basis. I'm doing Prolo or PRP
Okay.
for different areas of the spine and or joints. Um, we treat a lot of hip bursitis with PRP, and the success rate of hip bursitis getting better with PRP, like long term or nearly permanently, is really high. I mean, success rates of about 90% treating bursitis with PRP, getting one injection and being done forever with it. with a disease that really affects a lot of people kind of on a permanent basis, is a great option. Boy, that little sun in my eyes is just getting me there. Sorry
It's
about that.
moving. You're good.
It's the sun is setting here, so just one
Yeah.
second.
Thank goodness, right? We don't need the sun to do any more than it's currently doing here in Arizona.
No, if it's not heating up
Good.
my dashboard and steering wheel, it is definitely getting ready to cook me when I leave my office
Like
today.
113 here today.
Yep.
Okay, so tell me this as far as physical therapy, like what's the most common conditions that you will integrate therapy into physical therapy into your patient care treatment?
Yeah, the most common is everything.
Okay, just
I
you go
use
ahead.
I use therapy in every portion of it. I want therapy involved not only from the very beginning, trying to help me, a lot of these, let me put it this way, a lot of these patients when they show up in my office, being in East Mesa, we see a little bit of an elderly population more
Sure.
often than the acute young people injuries. Not to say I don't see them every day. It's just where I'm located. Same with you,
Yeah.
Mark, I think as well.
Yeah, we're right up the street from you.
So, a lot of these patients come in and I've had pain for 10 years. When they talk about 10 years of pain, they're not always certain where it started or how it
Yeah.
started or even what the past 10 years have been like. They just know they're at a point where, they can't sit on the couch anymore and pop ibuprofen or Tylenol or whatever they may be taking and function. And so my job is not only to like figure out what the pain is coming from, but to get rid of, the idea that you can age gracefully. Does that make sense? Like we just don't do that. There's no such thing as winning the battle of age sitting on the couch.
No.
You actually have to fight against it. It's an active battle that you must participate in. And so they
Yeah.
come in here and they have what may have started as back pain, but now both their legs hurt, their hips hurt, they don't want to move, they're unsteady on their feet. So right away, I mean, I'm putting them in physical therapy and saying, okay, well, your body hasn't really moved very well for a while.
Yeah.
Let's get it moving. Let's see how it responds to movement. Let's see what layers of the onion get peeled off. And let's put therapy to the test. What's the actual condition we're needing to treat, and what is a result, or what's like a secondary effect of being limited or having this condition for a long period of time? And so, right away, I am always a big push toward physical therapist. I like knowing my therapist. I like knowing what they do, what they're good at, what they love to treat, and really reinforcing to the patient, hey, you may have been to therapy in the past. We're going to do something. This is therapy 2.0. We're going to focus on not only the diagnosis, but I want to go ahead and start moving you in the right direction toward being healthy. I want stress, flexibility. I want strength. I want to correct imbalances. I want to peel off everything that is not your problem, that is not going to go away. And if I need to do something, I will, but let's work on those things first, and then we can actually find the root of your problem. So I'm really big into physical therapy.
Awesome. To illustrate that point, and that's exactly how I see our role as physical therapists. I had two incidences. One recently where my mom, she's getting up in age, she's in her mid 80s, and she's slowing down, which, to some degree is to be expected. But I know lots of people that are her age that are uh, have a lot more comfort and they're moving much better, right? So
Mhm.
her kids have been encouraging her to be a little more active because we know that'll help her,
They
right?
need that. They need a cheering section.
They need a cheering section. That's right. So my daughter was got married a couple weeks ago, and my mom went along with us, and she got on the airplane, and she hadn't done that for a while, and went to another state, and she was walking around with all of the events and activities associated with this wedding. When she went to get back on the airplane, like we were noticing, like she moves way better after 3 or 4 days of just being active,
Hmm.
otherwise than sitting around. And I said to my wife, I said, wow, look at the difference, just a little bit of activity. It was because it was my mom, and it had such a stark effect on me. I was like, then I was talking to my brother-in-law also, and he's a young, healthy guy, and he hurt his finger the other day, and he had a pretty good injury. And so he's telling me, man, if I don't move my finger, because he's rehabbing it right now, if I don't move that every couple hours, it's hard to make it move again. And I'm like, yeah, I could kind of connect those two dots together. Like, as we're getting older, especially like if we're not moving, which is, I guess it doesn't matter what age, if we're young, if we're not moving, the body stops wanting to move. And so whether we're getting injections or ablations or other additional help, we still, yeah, as the human condition, have to be moving. And I think that's one of the things that hopefully physical therapists which is our movement specialists. We're encouraging activity, not just strengthening, just not just range of motion, but active movements associated with what they need to be able to do in their lives. So I'm glad you're seeing it that way, because that's what I think we do add a lot to people's lives, and can help complement like the things that you're doing, complement what a surgeon can do, complement what other physicians are doing to help their patients. I think we do play a role there, so I'm glad to hear that. Um, let's see. What are questions I have here? What are do you have a recent success story that stands out to you that might, highlight how you used both physical therapy and what you're doing together to really see some type of a neat improvement in a person's life? Do you have anything that comes to mind as a story?
No, as like an attending doc that, teaches these things, my case, when you ask me that question, my mind goes to like the really obscure diagnoses that I've had to
Sure.
like figure out over the years. And,
Love it.
once we come into those cases, and come up with a diagnosis that everybody else has missed and make a huge turnaround. The hard part is a lot of those are very like tragic cases, where patients
Oh,
have
yeah.
really suffered for years, uh,
Yeah.
going undiagnosed and not knowing why nothing works and those kind of things. Um, uh, I'm not going to share that type of case with you while I'm
Okay.
on here. They're
Oh, now
very
you've got me wanting to hear it.
I've got a whole list on my desktop, and I actually do when patients, or not when not patients, but when other doctors come and interview here to go to our fellowship, I'll usually pull one of those cases
Yeah.
and I'll give it to him and I'll say, "What does the patient have? You tell me." And
Yeah.
of course, it's a lot of times it's such a difficult case. There's no chance they're going to get it, but I want to see how they react. How tenacious are they, or how hard are they willing to work to get the patient the answer they need so that they can be properly treated. So, but I'll give you a recent case I saw today. This is an easy one.
Okay.
Nothing spectacular, but the role of physical therapy uh, just was completely clear to me. This was a early 70s lady who came and saw me, who had fallen in her home and suffered a compression fracture in her back. And so when she went and to the emergency department gave her a brace, told her the fracture would get better, and sent her to physical therapy. And they also said, well, you need to go see a pain guy. They might be able to do something for the fracture. And so came and saw me here in the clinic, and went over their imaging, went over everything that happened. And it was actually, when I looked at the imaging, it was the type of fracture that really shouldn't have physical therapy just yet. Okay. So told her, okay, we need to put physical therapy on hold. We're going to go ahead, and I think the back brace is good. We need to do a medication to kind of improve your ability to heal that fracture up. Also, the medication to try and help with the pain in the meantime. She did actually undergo the fix, which is a kyphoplasty for the fracture, because she felt very disabled by the pain. She couldn't lay down. She couldn't sit. She couldn't just uh, breathe without the pain absolutely just
Bless your heart.
putting her out of commission. And so we did decide to go ahead and fix the fracture. We do that here in the office. Oh boy, that tree is really waving in the wind in the sun.
Yeah, no problem.
As long as it doesn't bother anybody, I'm just gonna ignore it and
Okay.
just looks like I'm becoming angelic here for a moment, maybe a few minutes. But
Nope.
uh uh so we went ahead and fixed the fracture. And about a week after we fixed the fracture, patient's feeling phenomenal and doing all these
So just
things.
pause for just a second. You fixed it. You guys did the kyphoplasty?
Yeah, so we did the kyphoplasty here in the office. We do
Explain what that is so we understand exactly what a
right. So,
kyphoplasty.
oh yeah, absolutely happy to. So, let me put this down just a little bit there. So, what we do to actually fix these fractures is we take a small, relatively small needle and we insert it into the bone where the fracture is at. We actually create a small cavity using a balloon. So we run a little tiny balloon through our needle and we inflate it, which creates a little small opening for us to fill with cement.
This is done under local anesthetic.
Under local anesthetic here in the office, it takes about 30 minutes to fix a fracture is all.
Okay.
So we create this little cavity using a balloon. We put some very special cement down the actual needle and it fills the fracture line in the back. The benefit of that procedure is it can almost instantaneously, if not within the first week, uh, significantly improve pain. We're talking about somewhere on the average of between 75 and 85% relief of pain when properly done. And it works in a very high percentage of patients. The uh, the reason we do that procedure is to help people feel better. But that doesn't necessarily mean that they'll immediately begin moving better. So this patient had fallen. She had kind of a new fear of falling. She had imbalance. Plus, she'd been inactive for by the time we fixed it, about 4.5, almost 5 weeks.
Mhm.
And so she starts feeling better, but immediately when I see her 1 week after the procedure at the post-op appointment, I know she's feeling better, but I'm looking at her going, yeah, you're walking very cautiously, and you almost seem to be limited in your ability to walk. Can you walk further than your to your kitchen, to your car at this point? She's like, no, I haven't been out of the house. I've been so confined. I'm afraid of falling. And, immediately the bells go off. Okay, we need therapy at this point. Now is the time. The fracture is safe. She doesn't have a broken back that she's going to therapy and trying to exercise with. Now her back is fixed. She no longer, has to deal with the pain from the fracture, but she has such debility and such fear of falling that's really limiting her ability to participate in you know, basic
Life.
activities of life, ADLs, as we call them in the business, right?
Yeah.
So, yeah, she was in therapy, and today was her like 4 week follow up from the actual post op. So she'd been in therapy for 4 weeks and just said, I forgot that I actually could function at this level, and this is what I was doing. And I got over my fear of falling by going to a therapist and having them just do, some gait activities, standing on a little ball and balancing, doing things that, um, reminded her of the fact that she can do it. She should have, confidence in her ability to walk. And it's important to do that, or it's just kind of a steady, declining fate from there on out. So yeah, so good case. Uh, the fracture was fixed successfully without any, real significant downsides. Patient went into a recovery physical therapy, and today is basically pain-free and functioning at her prior level. You really couldn't even tell she had a fracture at this point. So.
I did not know that you guys did that procedure. That
Yeah, so it sometimes is done in the hospital, like when patients go to the emergency room with these fractures. But the hard part is somebody falls and they have a back fracture, they'll get imaging but most of the time that imaging does not show the fracture until about 2 weeks.
Okay.
So it's so frequent that those CTs and X-rays are negative for an acute fracture that they end up in our office. Hey, I fell. They said I didn't have a fracture, but my pain is 10 out of 10. I can't do anything. In my mind, the kind of warning bells are going off. Well, this is probably a fracture. It's just you were there too quickly to actually get the correct diagnosis. So let's see what you got going on. We do some follow-up imaging, and yeah, there's the fracture, and now we need to deal with it. So,
That's really informative and good. Are there other procedures that I might be surprised to hear you guys like do also that we talked about a lot of things you do. Are there other things that like the regenerative stuff and of course the ablations and then spinal injections with fluoroscopy? What are there other things that would be good for people to know that you guys offer?
well, it goes along. I mean, the bread and butter of what I do are going to be like neck, back, joint injections, tendon injections. But with the introduction of kind of regenerative injections over the past 6, 7 years, are kind of it's broadened our horizons on what is capable with an injection. And so we find ourselves treating like chronic repetitive strains. We're treating golfer's elbow as well as tennis elbow successfully long term with these things. Things that you may not be aware of that we treat with injections are several nerve disorders like complex regional pain syndrome. I mean,
Okay.
that's a very difficult uh,
Yeah.
disease to manage for patients because it's almost all consuming. But
Yeah.
there are injections that we can do in the spine, or not in the spine, I should say, around the spine, onto a very specific nerve target that can provide kind of a general lessening of symptoms. May not fix the problem, but it does treat the symptoms enough to allow some alleviation of pain and return of function. Um,
What nerve is that?
yeah, so that is the sympathetic ganglia,
Okay.
located just in front of either in the neck, it would be the stellate ganglion, which is just in front of the C6 vertebral body. Uh,
Okay.
in the low back, we treat the lumbar sympathetic nerves with that, and that's really more of a chain. It doesn't have a specific name, but we treat that either in front of, most of the time, we'll say the L3 vertebral body.
Is it
Uh,
like a multi-site kind of like shotgun type of approach?
well,
Because
yeah, it's a large injection. So we do the injection here. Almost all of our spine injections are going to be done under fluoroscopy, live X-ray guidance. The way that we're actually able to visualize it is, let me see here if I don't have a model in my office, but basically, let me grab something.
feel free to grab one.
I got a vertebral level here that I can take a look at.
Okay.
So when we're doing injections in the spine, we're basically looking at an anterior posterior view or a view straight through the front and back of a person. So from the side, this would be the front of someone's spine. This would be the back of someone's spine. And we're looking at here straight down when we're doing an injection. Now, the actual place that we're trying to get is when we're doing a sympathetic injection for CRPS is on the front side of the spine. So the way that we actually get there when we're doing an injection is we rotate a camera around the patient until we can actually observe where the nerve lies right here on the front side of the vertebral body. And then from the back side of the patient, we are curving a needle down in past all this anatomy to where the nerve lies, and then doing a large injection where the actual medicine will flow up and down that sympathetic chain over several levels, blocking the signal that is creating the problem in their leg or arm. So,
Wow, this is great to know.
yeah.
That's how do you curve it? Just you have a curved needle?
We put a bend in the needle ourselves. Yeah,
No
that's
kidding.
that's kind of one of the advanced techniques that we at Desert Spine teach, kind of beyond most of our peer teaching programs. Is a lot of programs here in town. Well, not here in town, they don't. Um, Across the country, even the really high level ones are doing just injections where you kind of angle the camera and you're just supposed to bullseye it and put the needle tip where it's supposed to go. Here at Desert Spine, we're big on being able to get where we need to go safely. And a lot of times, the only way to do that is to put a bend in a needle and curve it around structures. Uh,
Hmm.
it takes a lot of training, but that's what we do here for an entire year. We teach you to bend a needle and to put it in the right location and be exact with it every time. I think that's probably one of the most satisfying parts of my uh, profession is I can be within a millimeter of where I need to be. I can be exactly on the location of where I need to be, or I can figure out how to get there. Um, and so it never leaves me wanting of, oh, I just couldn't quite get it just right. Like with a needle, it's very easy to be precise. So it
This is
satisfies me, the OCD portion that of my personality. So
this is fascinating and awesome. Well, I really appreciate you taking the time to giving that to us. I know you're busy with your practice and also with life in general, like we all are. But it's been super kind for you to give me some of your time and
yeah.
um,
I'm happy to help. I being born and raised here in Mesa, I feel a massive amount of responsibility to make this place happy. And nobody wants to have a bunch of grumpy drivers on the road, complain, they got back pain, so they're yelling at you for waiting at a red light. They need to get somewhere where they as quick as they possibly can so they can get out of their car so their back doesn't hurt. Um, but no, I feel a real sense of uh, being fortunate to practice, where I was born and raised. I love treating people here in town and, never feel like even though I'm busy, never feel like I'm too busy to reach out to if you have a question or you have a patient that maybe you could use an extra set of eyes or ears on. I'm always happy to help regardless of who it is. So,
well, and thank you for. I know you've been willing to allow our providers from our clinics to get to see some of the work that you do, and there's a real value in that for us, so that we know how we can refer people when they need to be when to over with you,
yeah.
and not just that, but just to know more about what's possible. And it's interesting. We all, when you go to physical therapy school, you don't honestly learn everything. Like I've learned so much in this little discussion we've had that I didn't know that will really help myself and my providers in our company. So I really appreciate it.
Well, I
And we,
appreciate you being a forward-leaning physical therapist and opening yourself up to these kind of experiences. I'm happy anytime, Mark. I'm always happy to have anybody from your office come in, and we're always happy to share what we have. I mean, nobody's going to grow in this field if we all keep our secrets. And so,
right.
yeah, let's try to do the best that we can for all those around us. So I appreciate the time you took to interview me today, and hope all is well. Be well, Mark. I appreciate all you do.
Okay, thanks, Art.
All right. Thanks. Bye.
Bye bye.